Heart disorder, cardiac disorders in pediatrics, right to left shunts. These are tetralogy of Fowler and transposition of the great arteries. Presentation is with cyanosis, blue, oxygen saturations less than 94% or collapsed, usually in the first week of life. Hyperoxia test or nitrogen washout test. The test is used to help determine the presence of heart disease in a cyanosed neonate. The infant is placed in 100% oxygen head box or ventilator for 10 minutes. If the right radial arterial partial pressure of oxygen, PaO2, from a blood gas remains low, less than 15 kilopascals, after this time, so after the 10 minutes, a diagnosis of cyanotic congenital heart disease can be made if lung disease and persistent pulmonary hypertension of the newborn have been excluded. If the PaO2 is over 20 kilopascals, it is not cyanotic heart disease. Blood gas analysis must be performed as oxygen saturations are not reliable enough in this range of values. Management of the cyanosed neonate. First, stabilize the airway, breathing, and circulation, the ABCs, with artificial ventilation if necessary. Then, start prostaglandin infusion, 5 nanograms per kg per minute. Most infants with cyanotic heart disease presenting in the first few days of life are duct dependent, i.e., there is reduced mixing between the pink oxygenated blood returning from the lungs and the blue deoxygenated blood from the body. Maintenance of ductal patency is the key to early survival of these children. Observe for potential side effects of prostaglandin, which includes apnea, jitteriness and seizures, flushing, vasodilation, and hypotension. Now we'll be looking at the tetralogy of Fowler. This is the most common cause of cyanotic congenital heart disease. Clinical features of TOF include in tetralogy of Fowler, as implied by the name, there are 4 cardinal anatomical features, as tetralogy, tetra means 4. So the features are a large VSD, overriding of the aorta with respect to the ventricular septum, subpulmonary stenosis causing right ventricular outflow tract obstruction, and right ventricular hypertrophy as a result. Symptoms of TOF. Most are diagnosed antenatally or following the identification of a murmur in the first 2 months of life. Cyanosis at this stage may not be obvious, although a few present with severe cyanosis in the first few days of life. The classical description of severe cyanosis, hypercyanotic spells, and squatting on exercise developing in the late infancy is now rare in developed countries, but still common where access to the necessary pediatric cardiac services is not available. It is important to recognize hypercyanotic spells, as they may lead to myocardial infarction, cerebrovascular accidents, and even death if left untreated. They are characterized by a rapid increase in cyanosis, usually associated with irritability or inconsolable crying because of severe hypoxia and breathlessness, and pallor because of tissue acidosis. On auscultation, there is a very short murmur during a spell. Signs of TOF. Clubbing of the fingers and toes will develop in older children. A loud, harsh ejection systolic murmur at the left sternal edge from day one of life, with increasing right ventricular outflow tract obstruction, which is predominantly muscular and below the pulmonary valve. The murmur will shorten and cyanosis will increase. Investigations for TOF. So the usual investigations: chest radiograph, ECG, and echocardiography. For chest radiograph, a radiograph will show a relatively small heart, possibly with an up-tilted apex, shown as a boot shape, due to right ventricular hypertrophy, more prominent in the older child. There may be a right-sided aortic arc, but characteristically, there is a pulmonary artery bay on a concavity on the left heart border, where the convex-shaped main pulmonary artery and right ventricular outflow tract would normally be profiled. There may also be decreased pulmonary vascular markings, reflecting reduced pulmonary blood flow. On the ECG, it will be normal at birth, but there's right ventricular hypertrophy when older. In echocardiography, this will demonstrate the cardinal features, but cardiac catheterization may be required to show the detailed anatomy of the coronary arteries. Management of TOF. Initial management is medical, with definitive surgery at around 6 months of age. It involves closing the VSD and relieving right ventricular outflow tract obstruction, sometimes with an artificial patch, which extends across the pulmonary valve. Infants who are very cyanosed in the neonatal period require a shunt to increase pulmonary blood flow. This is usually done by surgical placement of an artificial tube between the subclavian artery and the pulmonary artery, a modified Balloch Taussig shunt, or sometimes by balloon dilatation of the right ventricular outflow tract. Hypercyanotic spells are usually self-limiting and followed by a period of sleep. If prolonged beyond about 15 minutes, they should be given prompt treatment according to need, with sedation and pain relief. Morphine is excellent. Intravenous propranolol or an alpha adrenoreceptor agonist, which probably works both as a peripheral vasoconstrictor and by relieving the subpulmonary muscular obstruction that is the cause of reduced pulmonary blood flow. Intravenous volume administration, bicarbonate to correct acidosis, muscle paralysis, and artificial ventilation in order to reduce metabolic oxygen demand. Now we're done with TOF, tetralogy of Fowler. Now we'll be looking at transposition of the great arteries, TGA. The aorta is connected to the right ventricle, and the pulmonary artery is connected to the left ventricle. Discordant ventriculo-atrial connection. The blue blood is therefore returned to the body and the pink blood is returned to the lungs. There are two parallel circulations. Unless there is mixing of blood between them, this condition is incompatible with life. Fortunately, there are a number of naturally occurring associated abnormalities, for example, VSDs, ASDs, and PDAs, as well as therapeutic interventions which can achieve this mixing in the short term. Clinical features of TGA. Symptoms. Cyanosis is the predominant symptom. It may be profound and life threatening. Presentation is usually on day 2 of life when ductal closure leads to a marked reduction in mixing of the desaturated and saturated blood. Cyanosis will be less severe and presentation delayed if there is more mixing of blood from associated anomalies, for example, ASDs. Physical signs. Cyanosis is always present. The second heart sound is often loud and single. Usually no murmur, but may be a systolic murmur from increased flow or stenosis within the left ventricular outflow tract. In this case, the left ventricular outflow tract is the pulmonary outflow tract. Investigations for TGA. The normal 3 investigations of chest radiograph, ECG, and echocardiography. In the chest radiograph, this may reveal the classic findings of a narrow upper mediastinum with an egg-on-side appearance of the cardiac shadow due to the anterior-posterior relationship of the great vessels, narrow vascular pedicle, and hypertrophied right ventricle, respectively. Increased pulmonary vascular markings are common due to increased pulmonary blood flow. On the ECG, this is usually normal. On echocardiography, it is essential to demonstrate the abnormal arterial connections and associated abnormalities. Management of TGA. In the sick cyanosed neonate, the key is to improve mixing. Maintaining the patency of the the ductus arteriosus with a prostaglandin infusion is mandatory. A balloon atrial septostomy may be a life-saving procedure, which may need to be performed in 20% of those with transposition of the great arteries. A catheter with an inflatable balloon at its tip is passed through the umbilical or femoral vein and then on through the right atrium and foramen ovale. The balloon is inflated within the left atrium and then pulled back through the atrial septum. This tears the atrial septum, renders the flap valve of the foramen ovale incompetent, and so allows mixing of the systemic and pulmonary venous blood within the atrium. All patients with transposition of the great arteries will require surgery, which is usually the arterial switch procedure in the neonatal period. In this operation, performed in the first few days of life, the pulmonary artery and aorta are transected above the arterial valves and switched over. In addition, the coronary arteries have to be transferred across to the new aorta. Azamenga syndrome. If high pulmonary blood flow due to large left to right shunt or common mixing is not treated at an early stage, then the pulmonary arteries become thick-walled and the resistance to flow increases. Gradually, those children that survive become less symptomatic as the shunt decreases. Eventually, at about 10 to 15 years of age, the shunt reverses and the teenager becomes blue, which is Azamenga syndrome. This situation is progressive, and the adult will die in right heart failure at a variable age, usually in the fourth or fifth decade of life. Treatment is aimed at prevention of this condition with early intervention for high pulmonary blood flow. Transplantation is not easily available, although there are now medicines to palliate such pulmonary vascular disease.